Good morning. Thank you all for coming. I am indeed Ken Manas, and I'm going to talk on a topic that I've never presented before. I thought about giving this talk probably between 2 and 3 years ago, as I realized that I was reaching the 30-year mark, and that was a nice round number. So I thought that I would give this. Interestingly, last year, Dr. Muslow gave a talk on his experiences, and I think his, though, was 65 years. I actually did not get to attend that, and the idea preceded it, but if there's any similarity, it's purely coincidental. I doubt that there will be. Disclaimers, I have no conflicts of interest that I know of, and all of the stories that I may tell and relate are, to the best of my knowledge and recollection, true and accurate. So we always have to have objectives. When I started here presenting, I realized that we always had to go through this, and I never liked the fact that you had to choose these words so carefully, that the first word has to be a word that is something that you can measure. So anyway, I tried to adhere to that. I want to talk about some of the changes that have occurred, in particular in diagnosis and treatment in GI diseases, some technological advances and changes in the technical aspect of GI. Certainly, people often think of us as being proceduralists. I'll talk a little bit later about Jack Welsh, my chief of GI. But one of the things that I'm certain in my 2-year fellowship that I heard him say this no less than 50 and probably in excess of 100 times along the way to remind us, and that was, don't be a scope jock, be a physician. In other words, don't let your life center around procedures, but always remember to be a physician and be cognitive, not just procedural. Also, I want to talk about, or I'll touch on at least some changes, and I hope that you will appreciate them and this talk, but some of the changes that have occurred in the practice aspects of GI and medicine in general. So I said objectives, and then these are my objectives, actually. This is the way I would like to say it if I had the free hand and didn't have to worry about the constraints that I mentioned. So I want to share experiences, both personal and philosophical, and also some professional ones, but teach, and that's the professional and pedantic or educational aspect. And also, I hope that you'll get some entertainment from this, and so that's the fun aspect. Just to keep it, make sure you see the personal aspect and make it a little bit more warm and fuzzy. This is my teddy bear from childhood. I don't carry him anymore, but I still have him. Anyway, start off, I don't want this to center too much on me, but I would like to take a few minutes, and I'm going to try and go through this fairly quickly. Incidentally, I have a bad habit of not rehearsing lectures, so I really don't have any idea how long this lecture will take. My fellows and other people who've heard me talk can attest to the fact that I don't sometimes do time very well. I do space better than time. But anyway, I want to tell a little bit about me, and in particular how I got here, including medicine, GI, and LSU. So, to start with, I was born in New York, actually, on January 1st, 1949. When I was quite young, my family moved to Miami. My dad was, of course, South Florida was growing greatly at the time, as it still does, and he was in the building supply, roofing, and sheet metal industry, and my mother was a school teacher. I really had a fairly ordinary childhood until 1963, when a major event in my life occurred. It relates to medicine in general. The summer of 9th grade, in August, I developed a rash and was seen by my family physician, had fairly high fever, and a diagnosis of measles was made. I might add as a side note, back in the 1950s, and probably even later than that, when I was growing up, we didn't have MMR and all these other vaccines available. In fact, the first vaccine that I remember was when I was in about 1st or 2nd grade, and that was the polio vaccine. We took the Sabin shot and then the Salk and all that stuff, oral, and that sort of thing. But back then, before they had this, because there were childhood diseases, people often, parents, mothers in particular, perhaps, often had parties when somebody came down with measles or German measles or mumps or whatever, so that their kids would get those diseases during childhood too. Somehow and for some reason, my mother was fairly, I feel like I sound like Ben Carson now talking about my mother, but my mother was fairly sly and able to figure out how to keep us away from those things. So really never got those things when I was in my early childhood. But now I had measles, and in fact, I didn't get chickenpox until I was in my 40s when our daughter developed them, and then 2 weeks later to the day, I developed them, and later on in the day, our son developed them. So anyway, so this major event occurred that I had the measles, but that wasn't quite the major event. That was in August, and I started the 10th grade in September. And about 6 weeks into the year, I developed similar symptoms again. And we were kind of perplexed. I developed classic rash, started behind my ears, went down my body. We this time, instead of calling a family physician, called my pediatrician to see me, and or my parents did, and I had Koplik spots. I had classic measles at that point. That was early in the week, and on a Friday morning at the end of that week, I woke up with a nosebleed, and it wouldn't stop, and was taken to the hospital, and had my nose packed and was hospitalized because they found that my platelets were quite low, and from that point they went down further and further till they were down below 4,000 consistently for days and days. I was seen by an adult internist hematologist named Dr. Niebuhr, who was trained at Tufts and lived in Miami Beach where we lived. He diagnosed idiopathic thrombocytopenia, ITP. And I was started on 100 milligrams of prednisone a day. And after about 3 weeks, one morning they came in excitedly after my daily lab was drawn, sometimes twice daily lab, and said, your platelet count is 28,000, and that was really exciting. And from there, I did better. All of this kind of sparked my initial interest. I stayed under Dr. Niebuhr's care, and at that time, he had in his office this book, and we went to the bookstore and found this book, and I still have my copy, Blackiston's Medical Dictionary. And I would read about things that were maybe related to what was going on. I actually ended up back in the hospital for a few weeks with an FUO. That was a major event. I got out of the hospital in November of '63. I see mostly young faces here, so most of you will not be as struck by what also happened in November of 1963. John F. Kennedy, riding in a limousine in Dallas, was shot and killed that was a major event. I mean, we had 3 major news networks. We didn't have cable TV then. But all of these people were, all of this was on TV for days and days. Anyway, flash forward a little bit, and not too much happened after that. I went to college at Emory University. I then ended up at graduate school at the University of Miami, and then through some research that was doing, I had majored in biology and psychology, and I was working with behavioral psychology people, and kind of got linked up with somebody in the med school who was doing combined medical and behavioral research. He went on to become a surgeon on staff at University of Miami. His name is Jeff Augenstein. And, but we were doing studies on rhesus monkeys and doing surgery on them. We were doing thoracotomies, placing a blood flow cuff around the ascending aorta, putting EKG leads and a left ventricular pressure catheter that stayed indwelling. And then we did behavioral studies with different drugs and conditioned reflexes. Not something I'm proud of. It's kind of unfortunate to give poor little monkeys who are sitting in a hard monkey chair shocks to study them, but that was what it was. But all of this sparked a greater interest in medicine at that point. We actually did our own surgery. One of the first animals we did, the anesthesiologist showed me how to do anesthesia, and we did studies on an animal for 12 hours with me doing the anesthesia before we sacrificed the animal. So I had this greater interest, and so I applied to medical school and didn't get into the United States, and so I went to Guadalajara. There was a reasonably well-known school there. This is in a portion of Guadalajara called Lomas del Valle. It's a valley, as you can see. And the beginning part of the medical school, the first 2 years, is here. And then kind of towards the north end of Guadalajara, kind of on the outskirts, in a place called Tesistan, there was the 3rd and 4th year. This is one of the major lecture halls, and there were some classrooms there. And it was a very different environment from what you're used to, because first of all, I had to learn and had to learn in Spanish, take exams in Spanish. And this was a very conservative school in contrast to the state school, and so there were a lot of rivalries and issues that occurred. And so I don't know if you can see very well, but this is a rifle, and there were armed guards all over the campus. And every day when we drove into campus, we had to go through a stop point and all, and a search point and that sort of thing. So it was kind of different. I spent about 3 years there, and during the time there, toward the latter part, I had the opportunity to do some externships in the United States. One with a gentleman named Dr. Dietmar Gahn from Germany, who was a cardiologist at Mount Sinai Hospital in Miami Beach at the time, and now is in Tucson, and Dr. James Halsey, who was the head of neurology at University of Alabama, Birmingham, UAB. And I think these people played an additional instrumental role in seeing how I was and in writing supporting letters that helped me ultimately get into the University of Miami Medical School, where I spent from 1977 to 1979 before graduating. This person up here in the corner is Dr. Emmanuel Papper. He was the head of anesthesiology and also the dean of the medical school, and bears a connection to someone whose picture I'll show you in a moment. There's me when I graduated. A little change there, a little grayer and other things, a little different. But anyway, when I applied to medical school, I really focused on this part of the country. My brother, who was a labor lawyer in Miami, had planned and was looking forward to moving to Little Rock, Arkansas. So I applied at places in that general vicinity. I didn't actually apply here because I really didn't know about the medical school at the time, but I did apply at Arkansas. I applied at San Antonio. I applied at University of Oklahoma and at Tulsa. And I matched my first choice and was Arkansas, actually. My second choice was UAB because I really liked the place, but I knew I wouldn't get in there, but I applied anyway. And my third choice was Oklahoma. And I got in there. This gentleman also is Dr. Papper. This is Dr. Solomon Papper, the brother of Dr. Emmanuel Papper. And he was the head of medicine and really an amazing person. He was a nephrologist. He believed in humanistic medicine and was just a very inspiring person. This is Dr. Jack Welsh, who was the head of GI, and very interesting person. Ironically, although when I first interviewed at Oklahoma, I had no idea I was going to go into GI. I actually interviewed with the head of the medicine program, the head of the adolescent medicine program, and with Dr. Welsh. He was an interesting fellow in many ways, kind of a maverick. I remember when I walked in for my interview, he had his feet up on the desk, which was he liked to sit that way, was smoking his pipe. He had a great interest in Civil War generals and their medical problems. And also, like my current chief, Dr. Jordan, was an avid sailor of sailboats. So interestingly, there's another interesting link that I might mention between Oklahoma and here and Dr. Jordan, and that is, of course, Dr. Jordan's from Canada, and the Canadian River, which has nothing to do with Canada, quite ironically, flows right by Oklahoma City, as the Red River does here. So anyway, Dr. Welsh was quite a person. Dr. Ralph Guild, who's a fairly well-known gastroenterologist, said this about Dr. Welsh, and I think that it's very, very true. He was quite an inspiring individual. And he played an interesting role, in a sense, kind of in an indirect way, in how I ended up being here. And this is a kind of an interesting chain of events. We all had to do a project, and Dr. Welsh had seen a number of cases of women who had subcapsular hematomas associated with preeclampsia. And so he said, why don't you look into that more? And he gave me the names of a few patients, and I went to medical records, and I spent quite a bit of time going through all these records, and ultimately found that there were some things to write on, and I put everything together. I didn't bring it. I meant to show it, but I actually made a kind of a spreadsheet with it had 45 columns with all the different data for the patients that we looked at, and we narrowed it down to 7 of them, and really found that there were some interesting trends. And so I ended up submitting an abstract and presented this at the ACG in Los Angeles in 1983. And I have an avid interest in cinema, and it turns out this was held at the Biltmore Hotel, where many, many films have been made. And they were filming probably one of the movies that Tom Hanks is not so proud of, called Bachelor Party, kind of a raucous thing, as you might guess from the name. But I was very interested in watching, and so whenever I wasn't in sessions, I would go to the lobby and try and pick up on what they were filming and just watch. And towards the end of the time there, I was standing next to a lady who turned out to be the wife of Dr. Bill Wilder from here, who some of you may know, in gastroenterology practice. And we got to chatting and said I was finishing that year, and she said, well, you know, they're looking for a partner. So a couple of months later, I came to Shreveport and met with them, and I only knew one person here, or two actually, Dr. Alan Bourne, who's an internist here, and his wife, whom he met and married, she was a nurse at OU. And so I met with them, and it just seemed like a good idea. So I never actually interviewed anyplace else. I came here, and let's see where we are. So let's jump back. Not sure, let's see. So we talked about those things, and so ultimately I came to private practice in Shreveport. 1985 was probably one of the more momentous years in my life, as I'll show you. First of all, I met Tammy, who's now been my wife, and I might say we're in our 30th year of being married. So another little coincidence of sorts there, an overlap in my 30 years in GI. So we actually met. I actually first saw her at a Christmas party at one of the hospitals, but didn't meet her until after midnight one night. She worked in the intensive care unit at Shumpert, and I had a GI bleed that it was her patient. In March, I ended up having the highest billing for the group that I was with. This is an interesting sidelight, and one that I often think about the fact that when I got out of medical school and internship fellowship and all, internship residency fellowship, I thought to myself when I went into private practice, you know, it was a lot more fun when I didn't have to think about finances. Well, turns out that the people with whom I practiced would go every day and look and see how much their collections were, and that became kind of a pattern, and so I fell into that. In April, I was saved, yes. I was born Jewish. A nurse drug rep who called on us introduced me to the concept. I have no idea why things were going very well. Often people are down and out when they seek that sort of thing. And that was probably the most momentous thing in my life, because in May, I learned that my GI contract was not going to be renewed. It was very interesting because that week I had called Tammy and arranged our first date, and in between when we arranged that and when we went out, on June 4th, I learned that my contract was not going to be renewed. So it turns out that they felt that they didn't need another person. They waited about 2 or 3 years, and then they did get somebody, but that was fairly major. And the other thing was that in August, I made a decision to stay here and started my solo practice. So that's fairly momentous. I won't get Tammy to stand up. She won't be happy if I ask her to, but that's us then, and here's us more recently. Still with the gray tradition, more gray here also than here. But anyway, so that's about me in medicine. We covered up to that point. Changes in medicine led to the next thing that happened, and they really were changes that affected Dr. Jordan, not me. He was very resistive to a lot of the changes in payment and that sort of thing, and really started doing more general medicine, and there were some other things that went on that were that led him to move away from GI, and he realized that he wasn't happy doing that. There was a need here because the head of GI had left, in 97, and there was a great need for somebody to head up GI. In February of 98, he asked me to come over and at least cover a day in endoscopy, so I joined gratis faculty. In about May or June, he made a decision to leave his private practice and come here. And we stayed in touch. Of course, I still needed somebody to cover for me. And he said he would, but he kept telling me, he said, you know, I'm really having fun. You really ought to think about coming over here. And we talked about it. Tammy and I did, and I thought about it and all. And in August, I made a decision to come over. We had a GI fellowship program. What we didn't know was that it was on probation. And so the program got closed down in 2001. In 2004, we restarted the fellowship. And in 2006, I became program director by default because the ACGME realized that Dr. Jordan didn't fulfill the requirements because he was Canadian board certified but not US board certified. So I remained in that position until 2014 when Dr. James Morris took over the job and I became associate program director. So that's kind of the story about here. I'm probably running behind where I need to be, and I thought I'd go really fast through that, but I hope that part of things has been somewhat interesting. I want to talk about some of the changes. GI fellowship program is now 3 years instead of 2 years. Some people do a fourth subspecialty year or subspecialty for ERCP, endoscopic ultrasound, that sort of thing. The rotations that we had were kind of different. Here they rotate every month, and we did 3-month rotations either at the VA hospital or at University Hospital, and then we did 3 months of research in nutrition, not in nutrition, but nutrition and research, so that was our time. And we just cycled through that. So that was a difference. As far as training, so my first rotation was at the VA, and the attendings weren't always around like we are now. In fact, most of my training in the first 3 months was by a second-year GI fellow. It's quite different from what we do now. Supervision was also different. I was not on call the first month. The second month I was on call with a second-year backup and coming in with me. And then for the remainder of the time, I was on call and I came in by myself. Quite different when we do procedures here and that sort of thing. I think only one time in the 2 years did an attending come in, and it was for a private patient at University Hospital. That's a pretty big difference. Procedures, well, basic endoscopy was fairly much the same. There's a blip here, and there should be paracentesis, which we don't do very much anymore. We let the radiologists do that more now, often under imaging guidance. Same thing with liver biopsies. We used to do those. Also used to do laparoscopic liver biopsies and even lysed adhesions and things like that. And we also learned to do percutaneous transhepatic cholangiograms and did those. Dr. Rankin, my chief of GI, trained at Indiana, and they actually learned to do upper GI series and barium enemas, and small bowel follow-throughs. So some differences there and changes in patterns. So at this point, I want to talk about GI diseases and some of the changes that have occurred in these. And I'm probably going to need to go through this fairly quickly, and I want you to understand this is just really meant to be an overview. It's not going to be in detail, and I'm probably going to have to skirt over some of these things. But some of the key things that we deal with are reflux disease, certainly, Barrett's esophagus, and its association with adenocarcinoma. Eosinophilic esophagitis is something that's more recently gained attention. There's something called feline esophagus, in which there are multiple rings. It was well known radiologically. We saw it sometimes endoscopically, and for some reason nobody connected the dots to realize that it's an allergic kind of esophagitis, either airborne allergens or sometimes food allergens, and it is associated with dysphagia, amongst other things, but that's the main thing. So let's talk about GERD. It's common. Obesity is a risk factor. We had, at the time when I was in training, we had H2 antagonists, and partway through my training and toward the latter, we got a change from cimetidine to ranitidine, and then subsequently we got proton pump inhibitors, and that was after I was already out of training. Those certainly have made a big difference. We used to regularly see very, very severe esophagitis, which we see infrequently now by comparison. And we saw a lot more esophageal strictures back then. I would say that almost every day, particularly at the VA, we would dilate an average of 2 patients every single day. Esophageal dilatations are much less frequent now by comparison. So these are changes, and they've largely been brought about by proton pump inhibitors. We've learned about NERD, non-erosive reflux disease, and I can't dwell on that too much, but clearly there's a wide variation between or correlation between symptoms and actual findings endoscopically. Thus, there are some patients who have a lot of symptoms and do indeed have reflux, but they don't have erosive changes. Interestingly, with regard to Barrett's esophagus, the second-year fellow with whom I started working at OU was doing a study on Barrett's esophagus, and we were treating with H2 antagonists and reassessing patients to see if there was an actual regression of the transition point back towards normal. And partway through my first year, he presented some data, and I made the comment at our GI grand rounds that it seemed to me that there were many patients that had a lot of symptoms and had Barrett's, but didn't have, that had symptoms. There were also a number of them that had very little in the way of symptomatology and yet had Barrett's esophagus. And I remember Dr. Rankin was very upset by my saying that, because this was not evidence-based. And he stood up and said, you know, there's nothing that really proves that, but subsequently we have learned that that's the case, that there is a wide variation. So one of the things that might have changed things with GERD that we didn't have when I was in training was laparoscopic fundoplication. It really needs to be used selectively, and doesn't always work that well. There have been attempts at endoscopic anti-reflux procedures, suturing, radiofrequency delivery, injection of bulking agents in the distal esophagus to try and puff it up and close it down. The idea was that these things might be more reversible than surgeries. There was also something called an angel chick prosthesis, where they surgically put a little cuff around the GE junction. We actually saw a couple of those in training that eroded through, and that clearly fell by the wayside because it caused problems. A subsequent study done several years ago showed that none of these things really fulfills the necessary criteria to be good treatments. Anyway, proton pump inhibitors certainly have made a big difference. They've also played a role in reduction of rebleeding in upper GI bleeding. There are some issues that have been talked about medically and probably have some significance, and probably we should be trying to cut back on those wherever possible. Barrett's esophagus, various incidents. One thing to notice is, and what I mentioned earlier, a study done that looked at colonoscopy patients who were asymptomatic with regard to GERD who agreed to undergo EGD. Large number of patients, 56% of them had Barrett's esophagus, often short segment, but still Barrett's esophagus. Patients who have weekly GERD symptoms, percentage isn't that much more. Skip over that. There's long segment and short segment. Short is more is more common. Excuse me. We probably need to particularly screen patients who have long-standing chronic reflux disease, particularly if it's not been well controlled. Concept of low-grade and high-grade dysplasia. Dr. Morris does radiofrequency ablation here. There are other modalities, including photodynamic therapy. Radiofrequency ablation is probably the best option in patients with Barrett's esophagus who have dysplasia or even intramucosal cancer. Resective surgery for intramucosal cancers and even esophagectomy are other options. Certainly there has been a significant increase in Barrett's esophagus, even with us having PPIs and in death rate. And survival is not very good. Eosinophilic esophagitis I kind of talked about. We do have swallowed aerosolized steroids, and also now budesonide, a poorly absorbed steroid preparation to treat this. Dietary allergy testing and other allergy testing is also important in that. That's something that wasn't present when I was in training. Motility disorders. The biggest thing that's changed here is the development of high-resolution manometry. It's made a huge difference. We used to measure with four little catheters. Now we have a circumferential catheter with 36 points. We've learned a lot more. Achalasia, we knew about. Jackhammer esophagus is a newer concept that we can now recognize for people who have pain, atypical chest, non-cardiac chest pain, that sort of thing. As far as stomach and duodenum, there's not been a huge change here with the exception of the finding of H. pylori in particular. And interesting story that went along with that, I'll talk about in just a moment. Peptic ulcer disease, mainly NSAIDs and H. pylori, and certainly NSAID use increased markedly from when I was in training, with very, very high numbers being used beginning in the 1990s as more products came out. PPIs, as I mentioned, have helped. Endoscopy plays a big role in helping us diagnose and also intervene therapeutically, but interestingly, it has not changed the mortality associated with it. Anyway, one thing that has changed dramatically is resective surgery for peptic ulcer disease. That's probably due to medical therapy more than anything else, to some extent due to our ability to intervene in GI bleeds and that sort of thing. But it used to be a frequent thing for us to see patients that had Billroth surgeries, and now it's extremely rare to see them. Surgeons rarely do them. So another big change. H. pylori, the story really started in 1982 with Marshall and Warren in New Zealand. They recognized this. These little organisms had been seen all the way back into the beginning in the late 1800s. In the 1930s, Pepto-Bismol came onto the market, and probably it was effective to some extent, in part, in treating or assuaging the effects of H. pylori. Interesting thing about these guys is they self-infected themselves in order to prove that this was a valid mechanism. It's made a big difference, realization that it plays a role in gastric cancer, in MALT, lymphoma, Unfortunately, there's increasing antibiotic resistance, but once treated effectively, reinfection is rare, which is interesting. It tends to be oral, perhaps fecal-oral, and so anyway, small bowel, the big thing is celiac disease, media buzz, and people talking about it on TV talk shows in the morning and that sort of thing have brought more attention. Also, we've come to realize that it's much more prevalent than what we thought, but we still don't see as much as I would expect to see based on the prevalency rates. Capsule endoscopy has made a big difference in our ability to diagnose conditions in the small bowel, particularly small, subtle lesions, ulcers, vascular malformations, bleeding type things, and even NSAID-induced ulcers, things that don't show up very well on typical imaging studies. Enteroscopy, longer scopes, we can use regular scopes and push down further into the bowel. Also balloon enteroscopy, in which balloons attached to the outside of the scope let us go all the way down and examine the entire small bowel and also intervene endoscopically. So it's not an emergency procedure typically, it's more elective procedure. We can see things like NSAID-induced lesions and prove them. Colon. Certainly colorectal neoplasia screening is a major thing. It was present when I was in training, but has certainly taken off in a very big way, has become more accepted and paid for by insurance companies. Even Medicare is willing to pay for it, so that tells you something. Just mentioned about C. difficile, certainly that's increasing, and problems that we're facing are with relapse of it. Probably the big thing that's coming up is fecal transplant, and there are some interesting twists to that, including things like we may need to choose carefully whose stool we give, because there's now suggestion that the biome, the microbiome, actually has an influence that may even affect people in the way of obesity and things like that. There are some studies now that are showing that some people that got certain cultures of bacteria actually went on to gain weight unexpectedly. So there's some interesting twists there. Diverticular disease, not much has changed other than that there are some studies that now suggest that probably nuts, seeds, and popcorn and things like that don't play as big a role as we thought. Microscopic colitis, collagenous, and lymphocytic colitis were not very well known when I was in training. We see those every once in a while. Colorectal neoplasia screening, certainly there's an increased awareness and increased coverage that I talked about, and a marked increase in procedures done by us. It appears that the colon cancer rate is decreasing. It's been a fairly steady decrease since 1975, and there's still a 5% lifetime risk currently, and about over 1 million people currently living with the disease in the United States. But notable thing here is that the rate of new cases is decreasing at 3.1% per year, and that probably largely is due to screening and detecting of lesions early on, and the survival rate is also increased in part due to earlier lesions, in part due to better treatments also. One of the newer things in addition to fecal, or perhaps instead of fecal occult blood testing, is the FIT test, and so that's one of the things to think about. It certainly still, it's a major cancer in the United States, usually ranks second and third for men and women combined, although that may be decreasing now. This is for 8% of all new cases of cancer and 8.4% of cancer deaths. What about inflammatory bowel disease? Well, it's pretty prevalent also. In fact, it's becoming much more prevalent than it was when I was in training. Originally thought to mainly occur in Caucasians and certain Jews and at higher latitudes. But there's been a very significant increase, just in this small period of time. And this says our experience. And the reason why that's that way is that our experience has been very different. When I started out in 1984, probably I saw as many patients with ulcerative colitis as with Crohn's disease. But now we are seeing more and more patients with Crohn's disease by far. And we're seeing African Americans, and in our typical clinic, our fellows would tell you that a large percentage of patients that they see each time in clinic are patients who have Crohn's disease, if not hepatitis C. So anyway, there have been some significant changes. When I was in training, we had steroids and sulfasalazine, and that was all. Better aminosalicylates than sulfasalazine, and then ultimately immunomodulators, and then biologics. And we can test for antibodies to these and help to switch if we need to. And more recently, anti-integrins. And we also have IBD serology testing. What about irritable bowel syndrome? Well, this has been a place where there's been very interesting change, actually. When I was in training in early part of my practice, it was often thought of as purely a functional disease. It was said that 50 or 60% of the patients that you'll see in the office, especially female patients, will have irritable bowel syndrome. It's certainly not what we see here very much. It would be more like IBS that would take that percentage of what we see. Thought to be a functional disorder, now thought that maybe stress is a role, maybe sexual stress. There are some other concepts, including pain modulators and visceral hypersensitivity. And an important thing, GI infection as a precipitating event. And it's now felt that at least a significant percentage of people who present with typical irritable bowel type syndrome actually have had a gastroenteritis, potentially bacterial, as a precipitating event. And I want to jump down here to, and this should really have appeared there, antivinculin antibodies, which we can measure for, are associated with this. Another thing that appears to have some benefit is a low FODMAP diet, which is partly gluten-free, but also is low in fermentable sugars. The vinculin is part of the system that has to do with transmission of signals for motility. And when these antivinculin antibodies develop, that process is interfered with to a point where you may see constipative effects, or you may also see small intestinal bacterial overgrowth or changes in the flora. And so the microbiome may change, and thus there's now increased interest and thought about the benefits in some patients of treatment with poorly absorbed, in particular rifaximin antibiotics. HIV/AIDS, I don't have time to really tell the story about the first case that I saw in depth, but it was quite interesting, and it reflects. I'm going to go ahead and share it because it talks about something else that I want to mention. The first case that I saw was a gentleman who was married and had 3 children. This was at OU. And he had iron deficiency anemia and occult blood in his stool. His his workup got interrupted because he developed some eye and CNS infection, but ultimately he got back to us, and when we did his colonoscopy, we found some very unusual lesions. They were kind of polypoid. They had exudate on them. They were more proximal in the colon and decreasing distally, which was a little bit unusual. And we took biopsies, and a couple of days later, we got a very excited call from the pathologist saying that the patient had histoplasma capsulatum, excuse me. This was kind of surprising to us. We really didn't know at the time what to think about this. If you know the timing of when HIV really started to take off and be recognized, it was, am I correct, in the early 1980s. And it was a disease that we knew about because we heard about it because it was present in New York and Los Angeles and Miami and places like that, but certainly not in Oklahoma City, we thought. About a half year later, we had a visiting professor from Boston, Dr. Jerry Trier, who was a small bowel pathologist, and we said, or GI pathologist, and we said, let's present this case. And we presented this case, and he was up there at the podium. I can remember almost exactly what he said. He said, this patient has HIV until proven otherwise. We swallowed hard, because at that time, we did not follow any of the same precautions that we follow now. When we performed endoscopy, first of all, we had non-video chip scopes, so our eye was down here. The biopsy channel was right below. We used a gauze to pass the biopsy forceps in and out of the scope. The nurse would swipe. She wore gloves, and she would swipe that off and then pass it back to us. But one hand was bare, and the other one didn't have gloves either. It just had a gauze in it. And we said, oh my gosh. Well, fortunately, none of us contracted it. We actually scoped this guy twice because it was so interesting. We went back and took pictures because we didn't have routine picture-taking capability back then. So that was the first case. We saw many, many cases over the next several years, including here, and people who had all sorts of bad GI manifestations, bad infections, cryptosporidia, and other things. Of course, as the treatment got better, we don't see very much of that. Okay, pancreaticobiliary. I'm going to have to go fast. Changes. Big difference for us has been in MRCP and EUS, and that has led to less ERCPs. Pancreatitis, we now know that smoking and hereditary and autoimmune play a role. Pancreatic cancer, not much has happened. No improvement in 40 years in the survival rate, and not too much that we've found to help here. Maybe a little bit better surgery, but still a bad outlook. Biliary, laparoscopic cholecystectomies starting in the 1990s led to a big change for us, and more ERCPs for patients who had stones since open cholecystectomy and common duct exploration wasn't done very much. So more biliary endoscopy. Again, MRCP and EUS play a role and decrease our ERCPs because ERCP does have a risk of pancreatitis, and we don't want to do it unless we have to. New development in biliary is the mother-daughter type scope has been enhanced and perfected. Now is even digital with much better images, has biopsy capability, and we have that available here. So that we don't need. Liver disease. I'm really going to have to gloss over this because of time, but there are three things that are here, and early on, alcoholic liver disease was the major cause of liver failure. Subsequently, viral hepatitis, particularly hepatitis C, but also B to some extent, has taken over. But now what we used to think of as maybe cryptogenic cirrhosis and unexplained liver disease is now often explained by non-alcoholic fatty liver disease, NASH. Also, we learn more about autoimmune hepatitis. Acetaminophen has really taken off, and its importance is in combination, in particular with alcohol. You should be aware of that as a potential problem, and also herbal-related liver disease. As far as hepatitis, when I started out, we had A and B, and we had non-A, non-B. We knew it was there, but C wasn't defined until around 1989 or 90 in order to be able to test for it and detect it in the blood supply. The big difference is in hepatitis C in particular, identification. Also, treatment is one of the biggest things. So we went from non-A, non-B to hepatitis C, feeble treatments initially with maybe 15% response rates, then better with pegylated interferon, ribavirin, and finally with the addition of protease inhibitors, nucleotide analog inhibitors, we now can talk about actual cures and treatments that previously were feeble and lasted a long time, better part of a year. We now can treat in 12 weeks. In the case of Harvoni, with a once-a-day tablet with very minimal effects, side effects, and probably about a 97 to 98% cure rate. Second treatment, almost 100%. And these treatments work pretty well for all the varieties of hepatitis C. I want to talk briefly about obesity because I think that this is one of the important things that we don't focus enough on and deal with well enough. It plays a big role in many significant diseases, diet and activity, and perhaps psychology and behavior. Even as I mentioned, the microbiome may play a role in this. Procedures that have been done, I'm not a strong proponent of gastric bypass and those procedures. They are often life-changing in negative ways. We see a lot of complications. Patients eat around them. They ultimately gain their weight back. But Mayo Clinic says they're good. So there have been endoscopic treatments in the past. The Guerin-Edwards balloon I learned to use, but quickly realized that it had complications. There are a couple of new things, including a biodegradable balloon that can be passed endoscopically, and we may see some benefits there. We'll see. But the key thing is, I think, that it's undertreated and underdealt with. I mentioned about how we used to practice endoscopy. Now we dress up much more and gown up, in case you don't recognize the similarity. And some changes in endoscopy scopes, simulators not very helpful. Doing more colonoscopy, now using CO2, which we used to do and now has regained favor because patients have less distension. There's been a big focus on exam time and the quality of and the accuracy of exams and what's called adenoma detection rate, which is a big thing now that's being looked at, and we're expected to meet a certain level, and there's even suggestions that we may be paid based upon our adenoma detection rates, which is kind of interesting. But it is now felt that at least 7 minutes should be spent during retraction exam time, and that may even go up higher. It has been shown that typically for most endoscopists, the longer they spend examining, the higher their adenoma detection rate. So some changes in scopes and viewing field, wide view scopes. We may see that here. There's a kind of a rear view mirror device. Talked about that. There are lots of new tools and toys that I can't really talk about. Changes in bleeding, variceal band ligation, probably one of the biggest things initially. We just had sclerotherapy. We now do this prophylactically in some patients. In GI bleeding in general, nanopowder hasn't caught on. Neat devices that we're not using, but we might, a little implantable, endoscopically implantable bleeding detector. So you have a GI bleed patient, you tack this little device inside the stomach like a capsule. It's real small, and it actually has transmits to a little device that the patient keeps on the outside, and that device can alert them and even send a message to us by pager or by cell phone or whatever, letting us know that there's new blood in the stomach. So that might be kind of neat. Foreign bodies, kind of fun. We see all sorts of things. We see meat. One of the most enjoyable or interesting things that I had was with the pediatric surgeons, with Dr. Herbst, helping him get out a Nerf ball that had been in a kid's stomach and gotten quite hard, been there for several months. And when Dr. Barwani was here, a tiny toy BMW that we pulled out. As far as meat goes, this is me and a piece of meat that I pulled out on a patient. This is a message to make sure you chew your food well and take small swallows. Anyway, finally, I'm about to close, and I want to talk about a little bit about some of the things in medicine, Hippocrates. The actual Hippocratic oath that I think most people in U.S. medical schools take is a little different from the modern version. But some of the key points that are in the modern version that was written by Louis Lasagna from Tufts in 1964 is these things. And the ones that I really want to focus on, I put a little bit bigger. And this is a message that I think everyone should take with them, to never be ashamed to say that you don't know, nor fail to call for help when you need it. And remember that patients are sick human beings, no matter how they got there, whether it's through self-destructive behavior or whatever. And preventive medicine, and that's where things like obesity and screening for colorectal neoplasia and other things come in. One of the things that I had hoped to talk about was why we're in medicine, what we do, and where we derive our professional satisfaction. I don't have time to talk about some of the cases that I wanted to talk about, some interesting things that I've seen, but one is a case of a GI bleed, a patient that got flown in from Manny. I wasn't sure why. It was on a Saturday afternoon. When I came to see her, she looked fine. Midway through my interview with her, she suddenly said, uh-oh, and threw up a very large amount of blood. I won't be graphic about it, but it was quite impressive. And over the next 4 hours, we tried to stabilize the patient. I was hoping sufficiently to be able to scope the patient, but with the help of the anesthesiologist who got central line in, and Dr. Richard Kam, pulmonary critical care, who trained here and is in private practice here, we spent about 3 hours stabilizing the patient, giving a total of 12 liters, probably about 7 of red cells and 5 of crystalloid plus Hespan, at which point we rush rolled the patient. When we finally got the vital signs to out of the 50s to 60s range of systolic and up to in the range of 80 to 90, we rush rolled the patient to interventional radiology. Dr. Campbell, who did some of his training here, was waiting for us for about 2 hours, interventional radiologist, and he got in quickly and found this vessel and this bleeding site. He then proceeded to put coils in and stop the bleeding. Patient was on 3 pressors at the time. By the time we got out of there, was on 1 pressor. By the following morning, was off of pressors. A few days later, I decided to scope the patient just to see if everything was stable and to see what actually caused the bleeding. And in the duodenum on the medial wall, there was this ulcer that probably is partially healed. And there's a little bit of light reflection and something right here. But when you see close up, this little portion right here is actually this light reflection right here. But what you see in the close-up is one of the coils from the interventional radiology showing through. This is an example of why you need to call for help and never try and do it on your own. Complications do occur, especially in endoscopy and other misadventures. As Dr. Philip Cole from here says, if you don't want to have a complication doing endoscopy, don't do endoscopy. If you do have things go wrong, remember all of these things are important. Finally, just a little show of some of the group, and as I close, I want to give some appreciation. Dr. Jordan, Dr. Morris, appreciate all the rest of our faculty. Dr. Sheth, who's gone to Atlanta at his wedding. This is November, and it's No Shave November, and here's part of our motley crew. You may not recognize this one here, but if you see me later in the month, you'll know who it is. I grow my beard late in the month. Anyway, special thanks to my parents for helping me get through my education and for bringing me up, my educators, and some of them I've mentioned, the patients I've taken care of, students here, residents, our GI fellows who have been awesome and an inspiration, great to work with, our faculty, and I hope you all know who they all are. I don't have a list. My wife, because I don't think I could have gotten through all of this. In fact, I know I couldn't have without her. And above all, God, who gave me the ability and the opportunity to practice medicine. This is Maimonides. I did not take the Hippocratic Oath. Did anybody take the oath of or prayer of Maimonides? Well, Maimonides, a Jewish guy born in 1135 in Spain, you can see his achievements. He did quite a bit, and quite a diverse person. Died in 1204, and I want to just read this as we close. The eternal providence has appointed me to watch over the life and health of thy creatures. May the love for my art actuate me at all times. May neither avarice, nor miserliness, nor thirst for glory, or for a great reputation engage my mind. For the enemies of truth and philanthropy could easily deceive me and make me forgetful of my lofty aim of doing good to thy children. May I never see in the patient anything but a fellow creature in pain. Grant me the strength, time, and opportunity always to correct what I have acquired, always to extend its domain, for knowledge is immense, and the spirit of man can extend indefinitely to enrich itself daily with new requirements. Today he can discover his errors of yesterday, and tomorrow he can obtain a new light on what he thinks himself sure of today. O God, thou hast appointed me to watch over the life and death of thy creatures. Here am I, ready, my vocation, and now I turn into my calling. I hope that I've lived up to that, and I continue to. I hope that you have gained something from this. Thank you.